Welcome to Ulm Medical Center's show, Today's Health, where we are providing you with health information to help you live your healthiest self. I'm Carissa Bugler. I'm the Director of Operations at Ulm Medical Center, and I'll be your host today. Today we have with us Dr. Nate Grebner, is a radiologist at the Ulm Medical Center, and Dr. Corey Jordan, general surgeon at Ulm Medical Center as well, who recently just joined us.
Yes.
And today our topic is on breast health. So thank you both for joining us today.
Thank you, Carissa.
Thanks for having us.
Yeah, thanks. Why don't we start with just giving us a little bit about your background. Maybe Dr. Jordan, we can start with you if you want to tell us a little bit about your experience. And you recently joined us here at Ulm Medical Center, how long you've been with us, and what special areas of interest that you have as well.
Sure. So I came down here from the cities. I'd been in private practice with a group of surgeons up there for about the last 9-10 years, and covering a lot of ground in the metro area. My primary background in terms of training is in general surgery and trauma surgery, and over the years I've specialized in breast health, and I've done a lot of work with regards to breast health, breast cancer prevention and treatment. And so when I moved down here to Ulm, it was the middle of February, and it was 26 degrees below zero, and we settled in great. Since then, we've really established ourselves in the community here, and we're very happy. But during this process, we're helping to broaden some of the breast services that we're having here in Ulm.
Well, welcome. We're glad
Thank
you
you.
joined us.
Thank you.
And Dr. Grebner, tell us a little bit about yourself.
Yeah, so I'm a radiologist. So I specialize in medical imaging and diagnosis for the most part. I've been practicing in New Ulm for about 9.5 years now. I grew up in New Ulm, moved away for a number of years, and then came back after my training was done. So as a radiologist, as I mentioned, I do lots of different types of medical imaging, CAT scans, ultrasounds, X-rays, MRI. One of the larger areas of focus that I have is in breast imaging, and so I'm the one of the physicians at Ulm Medical Center that will look at a mammogram, look at a breast ultrasound to detect cancer and other diseases of the breast, and also I do a fair amount of the diagnostic work, working up abnormalities on a mammogram or an ultrasound by doing biopsies, which means to take a tissue sample from an area of tissue to figure out what it is, and so my focus in breast health is really on the diagnosis side of it.
Sure. Great. Well, thank you. Glad to have both of you on our medical team at the Ulm Medical Center. Dr. Jordan, you just joining us, one of the areas of interest that you have is around breast health and cancer. Tell us a little bit about a new program that you have proposed that you and our other two general surgeons, Dr. Paperniak and Dr. Newman, the three of you are partnering together to start a new program called the Breast Risk Assessment Clinic. Can you tell us a little bit about that?
Sure. So Breast Cancer Risk Assessment Clinic is a way for the average woman or woman with any considerable high risk factors to come in and talk about what is my overall risk. Screening, if we could create an ideal screening modality, it would be based on every woman's personal risk. But we run into challenges doing that because not everyone fits into a perfect little category where we can say all of these people should screen just like this. And so as you may know, there's a lot of questions around who should be screened, how often they should screen, when they should start, when they should stop. And this is an opportunity for women to get more information for what their screening process should look like. So they come in and meet with one of us surgeons. We can talk about their family history, their previous biopsies, whether or not they have dense breast tissue, and a number of other factors that would go into determining a woman's risk. And so we determine an appropriate screening process that's relevant for them. Not everybody knows what their risk is, and not everybody knows what to do when they get that letter in the mail that says you have dense breast tissue. Mm-hmm. Now what? So this is an opportunity to talk through that and find a program that's tolerable for the patient, tolerable for the physicians, and overall can prevent some breast cancers.
Could you speak to a little bit some of the criteria, or if women are thinking, oh, I have dense breasts, or I've been told I have dense breasts as a result of a mammogram I've had, or if there's a family history, what are some indicators that women should consider, maybe I need to go in for additional screening, or this is something I need to take a closer look at?
It's open to anybody. So, not too long ago, there was a law that was passed that women should be made aware of what their breast density is. Some women that have very dense breast tissue may not be adequately screened by mammogram alone, but a lot goes into determining whether or not that's a sufficient study or if more studies need to be done to give you the right answer that you're looking for. And so it's really helpful to sit down with a provider to talk through what that personal risk could be, whether or not more screening is necessary. And so since that law was passed, any woman with dense breast tissue is now going to have a little disclaimer sent to her that says, you have dense breasts? Now what do I do with this information? And providers were not always prepared for this as to what they should do when patients were to come in and say, now what do I do? I've got this ladder. So we were all kind of left in the lurch as to what would be the next appropriate step. So this helps to fill that gap. So we can have women either speak with their primary care physician and get the referral to this clinic, or they can self-refer through the clinic and come and see us.
Okay, that's great. So although there's no atypical or typical, this is what an assessment plan may look like. But can you describe what's the majority of women, what could they expect to see in a risk assessment plan?
Actually, why don't we field that with Dr. Grubner? Who are you seeing? Because he sees these women on the front end when someone were to come in with their screening. And so there are some women that we see that we would think is a little bit higher risk than the average woman and may benefit from having that talk. And there are some women that may just have some anxiety or not know a lot about their family history and would like to have that talk. But what criteria are you using?
Yeah, so really the largest, one of the largest predictors of lifetime breast cancer risk for a woman is having a history of breast cancer in her family, particularly if a first-degree relative, a mother or a sister, was diagnosed at an earlier age. And sometimes I see lots of women who are getting screened for breast cancer who may have what could be an abnormality on their mammogram, may be an abnormality, may not be an abnormality, and most of those women are at average risk. But occasionally I'll talk to a woman who has, and as we're going through her history, discover that maybe her mother had breast cancer, and her grandmother had breast cancer, and her aunt had breast cancer, and maybe a sister had breast cancer. And that can significantly increase a woman's risk for developing breast cancer in the future. And there are ways that we can estimate that risk, and there are ways that we can potentially do additional screening for breast cancer. Other things that impact your personal risk for breast cancer are whether or not you've had a biopsy before, a breast biopsy before. Not because the biopsy itself increases your risk for breast cancer, but we found that through studies of lots and lots of women, thousands of women, that having something on a mammogram or an ultrasound that looks a little bit different, even if it ends up being benign, increases your risk for developing an abnormality in the future. There are other things that put women at higher risk. Very dense breast tissue. So what does dense breast tissue mean? Well, breasts are made out of several different types of tissue, but it can be broken into essentially two types. One is fat, normal fat. That's normal to have fat in breast tissue. And the other is kind of everything else, the glands, the ducts, the ligaments in the tissues. And we call breast tissue dense if it has more of those glands and ducts and other types of tissue than the fatty type tissue. And that we found increases your risk for developing breast cancer in the future. And so family history, very dense breast tissue. There are certain other risk factors that you can see, but those are the major ones.
Okay. And what type of screening tools are used to identify or to screen for breast cancer?
Sure.
Clearly, many of us know mammography is a common screening tool. What other types of tools are available to women for screening?
So mammography is our primary tool. And for many years, we've been using two-dimensional mammography, which takes a two-dimensional picture of the breast tissue, because that's the one that's most tested and found to actually improve the chance of surviving, improve your life expectancy. We are now using pretty routinely three-dimensional mammography, which we've been doing here in New Ulm for, I think, about 2 or 3 years now. And that is a more accurate way of screening for breast cancer than 2D mammography in most cases. We can supplement that mammography with a couple different types of imaging and screening. The first is MRI screening. We do MRI of the breast tissue. That ends up being more sensitive. It picks up more breast cancers, but it has some drawbacks as well. It also picks up lots of things that aren't breast cancer, and so you may come in for a breast MRI and find something that's potentially abnormal on the MRI, and then the next step would typically be to do a biopsy of the tissue, to take a tissue sample. For MRI, we end up taking lots of tissue samples, doing lots of biopsies on things that don't end up being cancer. So in order to, so we found through studies of, again, thousands of women that it seems like women who are at higher risk of developing breast cancer in the future benefit more from having routine MRI screening. So, ultrasound is another type of screening that we can do. We aren't typically doing ultrasound screening at Ulm Medical Center yet. It hasn't been tested quite as much as mammography and MRI, but it may be something potentially in the future. So.
And Dr. Jordan, are there other screening tools or other recommendations that you would have for women as well when it comes to screening for breast cancer?
Screen for breast cancer. Make sure you're going for your mammograms every year. So I want to add a couple things on there. So if you think about traditional two-dimensional mammography that we used to do, you're taking the breast tissue, you're compressing it between two plates, and you're hoping to discern the different subtle changes within the breast tissue with that compression alone. So doing traditional 2D mammography, you get two images. When you do 3D mammograms, you're not only compressing the tissue, you're also getting like a 360-degree view, or 100. How many degrees? 170, 280? What is it?
Yeah, it ends up being about 50, but
you get a lot more images. So it's kind of, instead of trying to look at the breast as though it were a book and look through the book to find the information, you're actually looking through the book page by page to get the information. It gives you a lot more information with the same amount of imaging. And so it's really helpful, especially for women that have dense breast tissue, to get that subtle information. And so 3D mammograms are definitely preferable for that. Doing regular screening for the average risk woman with an MRI alone is typically not recommended because it gives you so much information. That information needs to be used really judiciously. So if we are looking for someone who is seen as being higher risk based on family history, based on all the other factors that go into that, MRI is useful in conjunction with 3D mammograms, and we usually alternate that every 6 months, with the thought process that if the mammogram is catching you once a year and the MRI is catching you, halfway between that cycle, those subtle things that would pop up in between mammograms would be an opportunity for intervention before something becomes really out of control or needs something very dramatic to treat it. And so that's why those two modalities together work really well. So if you think of your risk for having breast cancer as like a bucket, and what goes into filling that bucket will be a number of different things, but once your bucket is full, you're going to have a breast cancer event. The most significant thing that fills up that bucket is family history. But there's a lot of other things that go into that. So if you don't have a family history of breast cancer, you can still get breast cancer. And that's why it's important for you to continue to screen and be diligent about seeing your provider and doing your breast exams. The other things that go into that are history of atypical biopsies, breast density, kind of what's in the food that you're eating and the things that you're exposed to in your environment, whether or not you have a genetic predisposition to something, and all those other factors that go into that. Anything to add?
I mean, that's exactly right. You know, one of the kind of the concept of screening is kind of important, and it can be a bit subtle at times too. But what we're trying to do with screening is to find essentially a breast cancer at the point where we can treat it and save a life, or at least prevent health difficulties down the road. And so, over time, as medical knowledge has advanced, we've gone from kind of very, and this is in general with screening for cancer and in multiple areas, but we've gone from very kind of blanket across the board recommendations based on trials of thousands and thousands and thousands of people, trying to hone that down more, realizing that everybody's different, and not only different in terms of what is their risk for developing the cancer, which we can get at through data, but also what is every individual person's kind of concept of that risk, and how much are they willing to do based on that risk. So one woman with two women with the exact same mathematical estimated percentage of developing breast cancer in their lifetime may have very different ideas of how concerned they are about that risk, how much extra medical testing they want to go through, and that's really one of the advantages, I think, to having a clinic, having a resource like this available to help talk through those things and help everybody, every woman who's interested, develop a personalized plan.
So what I'm hearing from both of you is there's all these tools available, and as physicians, you're guiding us through, here's what we recommend, but there's personal choice in that of how much screening do I want to do, and then if something is found in screening, what would I do then? So maybe let's move on to that. Let's say patient has a mammogram and something is found on the mammogram. How do we go about determining, is it something to be concerned about or not?
Sure. So there are a couple ways that, that women get to that point. The first way is through a screening mammogram. So you have your yearly mammogram, and the radiologist looks at the mammogram, and there is something on the mammogram that looks possibly abnormal. Looks a little bit different from what you're expecting. That's the first way. The second way is if a woman has an actual physical abnormality, feels a lump, has a change in the skin, change in the look of the skin, has some discharge, and then comes in not having had a screening mammogram recently for us to evaluate. So what we would do then is we would go to extra mammogram pictures, and we would do some focus pictures of that area on the mammogram machine. And we may or may not, but usually we do take ultrasound pictures as well. And ultrasound works differently from a mammogram. Mammogram uses very low energy or very low dose X-rays to make pictures of breast tissue. Ultrasound uses sound waves, high frequency sound waves, and sees the tissue in a different way. They're complementary. And then it's the job of the radiologist to put all of that information together, put the pictures together, put the history of the woman together, if it's a lump or if it's discharge, kind of put all the information together and come up with, well, what would we recommend in this situation? You know, what is the risk that this potentially abnormal area? What is the risk that this area is actually abnormal? And then what should we do about it? And so at that point, have a discussion with the woman and say, this is the chance that this is an abnormality. And typically, if it's more than about a 2% chance of being breast cancer, then the recommendation is to undergo a biopsy, which is just taking a little sample of the tissue of that area with a needle. Okay. So, and after that, it depends upon what the result of that biopsy.
Okay, so something is found, a biopsy is done. What happens if the unfortunate news is it appears to be cancerous? What options are available at that point for the patient?
Depends on the type of histology. So the key with this whole trajectory from workup to diagnosis to surgery to whatever treatment is that shared decision making between the provider and the patient is the key aspect of every step. And so you'll sit with your provider for every step of the process, and the patient has been given risks and benefits of everything in terms of screening, not screening, biopsy, not biopsy, and then treatment plan, and really helps drive the direction that they want to go. So we empower the patient with the information and just serve as a guide, not like what we used to do where we would just tell you what to do. And I think that really gives patients and women a little bit more control in a situation where they're otherwise vulnerable and don't have much control over what's happening to them. And I think that's important to highlight. But once they're given their diagnosis, let's say it's a breast cancer, there's different varieties of breast cancer and different treatment plans that are tried and true for the certain subtype that they have. Some types of breast cancer benefit from chemotherapy up front. Some types of breast cancer benefit from surgery, and some types of breast cancer don't need anything else other than just surgery. And so there is a long discussion with what would be an appropriate care plan and then what the patient wants. In terms of surgical treatment plans, there are two major ones that have been tried and true. One is a lumpectomy, or breast conservation therapy, where you remove the tumor and a small room of normal appearing breast tissue, and a lymph node is usually biopsied, and we see what the result of that is. For some women, that may be all that they need. Some women will also need radiation as part of that care plan. And those two things usually go together for most women, but there are some select cases where the radiation isn't necessary. There's also an opportunity to have a mastectomy, which is a removal of all of the breast tissue, and the opportunity for reconstruction at the same time, or delayed reconstruction with a plastic surgeon. There will be some cancers in some patients that will benefit from mastectomy more so than just a lumpectomy, but for most people, the survival is the same for both. And so a lot goes into that decision-making process, whether or not you're willing to have radiation. How much surgery do you want to have? Most people don't want any surgery. So we talk through that. Body image is a big discussing point. And for most women, you can talk to them about body image for days. So that's part of the discussion. And then anxiety over future screenings, future biopsies, and those sorts of things. And so there are a lot of options, a lot of new options. And one of the key things that we are bringing down to New Ulm is that we have a plastic surgeon that will be on site to offer our reconstructions, so that women don't have to travel. They can have all their care closer to home, which is great.
That is great.
Mm-hmm.
Thank you.
You're welcome.
So for women who maybe don't have a family history or personal history, don't have dense breasts, there's all this literature out there around how often should I get a mammogram? And how would you answer that question? If a patient doesn't appear to have a lot of risk, what's your recommendation?
So that has been a controversial, has been controversial in some circles for years and years and years.
You
and
have all the answers, I think.
Well, there are multiple different recommendations. There are several groups, national groups, that recommend anything from once every 2 years at a certain age to once a year at a certain age. Okay. The recommendations beginning at age 40, recommendations beginning at age 45. Most medical groups recommend once per year at age 40. And so I think it's fairly clear that the earlier that you start screening, the more breast cancers we pick up. And so starting at age 40 and screening once per year, we will find more breast cancers. Now, again, these are recommendations that are based on studies involving thousands and thousands, hundreds of thousands of women. They're not recommendations that are based on what your preference is. And so when I counsel a woman about that very question, typically what I say is, well, exactly what I've just told you. We do know that we find more breast cancers when we start screening earlier and when we screen more frequently. But we also do more biopsies of areas that don't turn out to be breast cancer. You come in once a year instead of twice a year. You may be you may have anxiety over coming in every year or waiting for a result. So it's ultimately your decision, but you need to know the risks that are involved and the benefits that are involved. If someone asks me straight out, what do I recommend? Once a year starting at age 40, but I'm not you. So it really, I believe, is a personal decision based on, but it needs to be based on the facts.
Sure.
I think important to highlight that there's a couple things. Once a year starting at age 40 and continuing until you have a life expectancy of, let's say, 10 years or less, or you come to that point in your life where you're not so interested in undergoing therapy. So if you were to, let's say you're in your 80s and you've got a lot of other health problems, and if someone were to say you need surgery or chemotherapy, you wouldn't do it, then there's no reason to go looking for it. And so I think that's important to highlight. Also, when we're doing them every year starting at age 40, we may catch more breast cancers, but the key to that is that we're catching them when they are early and treatable with a single stage treatment plan, meaning just surgery. You're not often going to need chemotherapy, which means that you're not going to be missing work and missing out on lifestyle things that are important to you. You're not being taken away from your family for long periods of time when you don't feel well. And that is the benefit in doing screening early and often. Yes, we may, if we fall off that screening regimen, miss out on some of the ones when they're early and catch them when they're a little bit later, but now you're looking at bigger surgeries, longer times away from work and family, more therapy in terms of chemo and radiation, and more times where you don't feel well. And so there's an opportunity to do prevention there that I think is important.
Okay, that's very helpful. Thank you. Let's talk a little bit about prevention and just women taking care of themselves. So, Dr. Jordan, you are a yoga instructor.
I am.
And very committed to living a healthy life. You, Dr. Craig Nur, as well, you serve on the leadership committee for the Heart of New Ulm initiative. What recommendations do you have for women when it comes to cancer prevention or just self-care in general?
Do you want to start? Or
Yeah,
should
sure.
I take it?
I tell all of my patients that you need to get some sort of Fitbit or activity tracker and make sure that you're hitting 7,000 to 10,000 steps every day. It's an arbitrary number. It was really brought about by a Japanese company where the Japanese character for 10,000 looks like a man walking. That's where that number came from. There's no magic behind it, but it's just something to shoot for, and that comes out to somewhere between 3 to 5 miles a day. And that's just in passive, natural movement. It doesn't need to be 5 miles on a treadmill. It can be, and that would be great, but most people aren't into that. So just natural movement, and then watching what you are putting into your body in terms of diet, clean living, clean eating. So eat real food, nothing in a crinkly package. Stay away from the middle part of the grocery store. Everything you need is on the periphery in terms of fresh things. Not too much, meaning don't overeat, everything in moderation. And then mostly plants. So eating a healthy dose of fruits and vegetables every day. Minimize the toxins that you're putting into your body. So that means minimizing the plastics, the vinyl chlorides, the things on the ingredient list that are 10 pages long, probably not real food, and you probably shouldn't eat it or take it into your body. Those are important things. Making sure that you surround yourself with people that treat you well and make you happy, and that there's something in your life that you're passionate about, because if you have a healthy mindset and you have a purpose every day, you're going to do well.
That really is the key, and it's kind of, we're finding the more we discover about what makes people healthy and happy and live long lives, the more it all boils down to those very few things. And whether it's preventing breast cancer, preventing colon cancer, preventing or staving off Alzheimer's disease, extending your life to it really comes down to essentially living the way humans are supposed to live, and eating natural foods, mainly plants, moving your body, moving your mind, staying active physically and staying active mentally, having friends, engaging with friends and family. It's really, if you think about what are humans supposed to do, those are the things they're supposed to do, and that's what keeps us the healthiest. So it's very simple in concept. Sometimes easier said than done, and kind of with the way our modern lifestyle is organized. But I think those are really the keys.
Well, those are great words of advice for us to end on. I thank both of you, Dr. Jordan
Thank you.
and Dr. Craig Nur, for joining us today. If you would like to discuss your risk for breast cancer and better understand screening tools and other options available to you, please call the Ulm Medical Center at 217-5011 and schedule an appointment with your primary care physician or one of our general surgeons, Dr. Jordan, Dr. Newman, or Dr. Perperniak. All of our team at the Ulm Medical Center will be glad to help you better understand your risk and provide those tools to you. For more information, you can also visit our website at alinahealth.org/Ulm Medical Center. Thanks for joining us today.
Thank you.